My name is Tom LeGrand, and I want to welcome everyone wherever you are and what time zone you're found. I want to welcome you to this research leader session on new evidence on urban fertility and family planning in Sub-Saharan Africa and in South Asia. The session is sponsored by the IUSSP Scientific Panel on Urban Family Planning. The topic of this session is, in my view, of immense importance to the socio-demographic future of our world, and it tends to receive much less attention than it deserves for both the population studies and urban studies fields. Before starting the presentations, I'd like to make a few points. First, over 3/4 of world population growth from now until 2050 is projected to take place in Sub-Saharan Africa and, to a lesser degree, in South Asia, the two regions of the world that account for 85% of the population that lives in extreme poverty. From 2050 to the end of the century, all population growth is projected to take place in Sub-Saharan Africa. The bulk of future population growth will take place in urban areas, and this is especially the case for Sub-Saharan Africa. Today, most of the world's largest cities are found in Asia. In 2010, only 10 of the world's 100 largest cities were African, while at the end of the century, 38 are projected to be African. And another projection I saw shows 13 of the largest 20 cities of the world will then be in Africa. Recent work by Ashira Manash-Oren and Philippe Bocquier showed that urban population growth in low and middle income countries over recent years has been primarily due to natural increase, the greater number of births and deaths, and not to rural urban migration or to the expanding physical size of cities as the cities grow. Bruno Schumacher, who will present his work in a few minutes, has shown that fertility decline has stalled in many of Africa's largest cities over the past 2 decades. If that tendency is maintained, Africa's population growth risks being faster than that projected by the United Nations and not slower, as researchers at the Wittgenstein Center and the Institute for Health Metrics and Evaluation have argued. Clearly, the importance of Africa's cities is rising rapidly, and efforts to improve human welfare and environmental sustainability must place a much greater emphasis on them. Population researchers often account for the effects of urban life by simply adding a dummy variable for urban-rural residents into their regressions. Cities, however, are extraordinarily heterogeneous, with population subgroups living vastly different lives and facing hugely diverse constraints and opportunities, and they cannot be captured by one simple indicator. Demographers and other social scientists must do more to take this variability into account. Unwanted fertility in the rapidly growing cities of the global south typically remains high, and the rapid rise in the number of adolescents and the large size of other disadvantaged subgroups translates into enormous needs for targeted sexual and reproductive health services. Universal access to high-quality family planning services in particular must be a key part of efforts aiming to build sustainable and vibrant cities, UN Sustainable Goal number 11. Providing couples with the ability to plan their families is of immense value in terms of women's economic empowerment, enabling young women to invest in their schooling and careers, and giving families the ability to invest more in their children's schooling. Elements of critical importance to human welfare and gender equality, as well as to achieving the demographic dividend. Targeted family planning programs can also bring real benefits in terms of maternal health, poverty alleviation, and increasing households' resilience to shocks. And slower urban growth facilitates the achievement of many other urban development goals. Today, we have 4 very interesting studies on urban fertility and family planning in Sub-Saharan Africa and South Asia. Professor Nkechi Uwu of the University of Ghana will then present her remarks on these studies. And afterwards, I'll give each of the panelists a chance to respond before we open it to questions and comments from the audience. For questions and audience, please write your questions or comments into the chat, but I've also enabled the raise hand button. If you prefer to give your question orally, raise your hand and we will call on you. Okay, I'm just checking to see who is here. We were waiting for Alex Eze. Sorry, yeah, Alex is here. Alex, are you ready to present? You will need to share your presentation, please.
Okay, I had uploaded it in the system. I don't know. Do I do it from here?
Yes, please do it from here. We don't find it in the system.
No, I found it in the system. I'm having it sent to the tech, but if you're ready now, you can go ahead.
Otherwise, if you want, we could inverse the order and put you second, if you would prefer.
That would be fine.
Okay, so instead, please, Nancy, if you could start with the Challenge Initiatives Business as Usual presentation by Ian Salas.
Hi, my name is Ian Salas. I am an assistant scientist at the School of Public Health at Johns Hopkins, and I am the senior technical advisor for the Challenge Initiative, or TCI. It is my pleasure to share with you today more information about TCI and the results we have seen in its first 5 years. Many of you might have heard that by 2050, 70% of the world's population is expected to be living in cities. Most of this growth in the urban population will be coming from Africa and Asia, and it will mainly occur in poor urban slums. Recognizing this problem, global leaders and stakeholders have started to take action. In 2009, the Gates Foundation funded what's called the Urban Reproductive Health Initiative, or URI. This was established in 4 countries in Africa and Asia. URI was considered a proof of concept program to identify high impact family planning interventions that will improve the reproductive health of the urban poor by increasing the accessibility, quality, and use of family planning services. URI succeeded in its goals, and in 2016, the Gates Foundation launched the Challenge Initiative to incentivize the scale-up of proven high-impact interventions from URI and others in many more locations. In July 2020, Bayer AG joined the Gates Foundation in funding TCI, and both donors have invested in an expansion of TCI's work until 2025. Aside from its focus on urban family planning, what else makes TCI unique? First, TCI uses a co-investment model. Cities self-select to be part of the platform. They commit their own resources to their local family planning programs in order to unlock funding support from TCI. Second, city governments lead the implementation of high-impact interventions, not TCI. What TCI provides is coaching support to strengthen local government capacity and self-reliance. Third, TCI is results-focused and action-oriented. It developed an innovative and efficient learning and monitoring platform to ultimately deliver sustainable impact at scale. Now, the figure on the right shows a local government's journey with TCI, from self-selection to committing resources, to surging implementation, then eventually to pre-graduation and graduation. This entire engagement process takes about 3 to 4 years. Since it started enrollment of cities in September 2017, TCI has supported a total of 104 reporting cities by June 2021. Covering a total footprint of 103 million people. This chart illustrates how TCI has rapidly scaled up in the past 4 years, responding to huge demand from local governments in 4 different regions: East Africa, Nigeria, India, and Francophone West Africa. Now, TCI is positioned to expand even further and cover a footprint of 170 million people by the end of 2025. So what are those high-impact interventions for which TCI provides coaching support to city governments? Here is a list of those high-impact interventions by region. This shows a mix of activities to support a conducive policy and program environment for family planning, to generate demand for family planning in the community, and to enhance the delivery of family planning services to women and couples who would like them or want them. These activities are spearheaded by the local government and are responsible for the outcomes we see in our cities. Now, the items in bold are the key high impact interventions by Hub. All activities are important, but most facilities conduct these specific interventions in bold. That's the whole site orientation in East Africa, universal referral in Francophone West Africa, fixed day static services in India, and enriches in Nigeria. This slide shows the increasing number of facilities implementing TCI's key high impact interventions. As of June 2021, 940 facilities have completed whole site orientations in East Africa. 518 urban primary health centers have been activated in India to provide fixed day static interventions. 622 facilities have undergone performance improvement assessments in Nigeria to determine what level of support they need and which interventions are most appropriate. 543 facilities are able to provide universal referral services in Francophone West Africa. The scale of these high-impact interventions continues to grow as TCI deepens its work in the current cities while also expanding to new ones. And these are just examples from a fuller list of indicators that track TCI's strength of implementation. Now, TCI has a wealth of data for program monitoring and learning, covering both quantitative and qualitative measures. TCI records, project records, and service statistics data from HMIS are collected for all TCI cities on a near real-time basis. TCI also conducted surveys previously and uses other available surveys for triangulation. On the other hand, qualitative measures include the regular use of the most significant change technique, quarterly pause and reflect sessions, and city government's use of a self-assessment tool for sustainability and program effectiveness that we call RACE. This presentation will focus more on the results from HMIS data. TCI collects monthly service statistics data from HMIS in all of its partner cities. We process this data to check for outliers, to adjust for seasonality, and to calculate the 3 different indicators which gauge the effective number of women who received protection from pregnancy in each 12-month period. This slide now summarizes the changes in contraceptive uptake indicators seen in TCI cities since they started partnering with TCI and started implementing the high-impact interventions. Overall, 815,000 more clients received services in TCI cities in the latest 12-month period ending in June 2021, compared that to a 12-month baseline before TCI implementation. This is a 44% increase in annual client volume from baseline to June 2021. When these number of clients are accumulated, we have calculated an overall total of 2 million additional users since the start of TCI implementation until June 2021. This number accounts for revisits made by users of short-acting methods, as well as discontinuation by users of long-acting methods. Now, this translates to a 2.49% derived change in MCPR, or DCM, per year in TCI cities. All these indicators show positive signals of TCI's contribution to increasing contraceptive uptake in the different TCI cities. Given these positive signals, the next question for TCI was, how do the trends in TCI cities since TCI implementation compare to a period before they partnered with TCI and began implementing the high-impact interventions? To answer this question, we look more closely at 84 cities with more than 18 months of TCI implementation data. Now, the red line shows the average yearly derived change in MCPR across all 84 cities. Before TCI began implementing, there was a 0.65% DCM, or derived change in MCPR. In the first year of TCI implementation, we see a 2.44% derived change in MCPR, and this has improved to 2.92% in the city's second year with TCI. Now, these trends vary by regional hub, with East Africa and Nigeria showing the strongest before and since trends, followed by India. In Francophone West Africa, TCI has been actively addressing challenges we've encountered in working with local governments and public health systems. We regularly monitor the performance of each city to learn from practices in high-performing cities and to understand what's holding back low-performing ones. Now, the leftmost pie chart shows that overall, only 20 TCI cities out of 104 have lower derived change in MCPR since TCI implementation compared to baseline, meaning 80% of TCI cities performed better than before TCI. You can also see performance changes grouped by region in the smaller pie charts. It shows that most of the cities facing challenges come from Francophone, West Africa, and India. Now, the last question we aim to answer as part of this presentation is, are TCI cities exhibiting a performance advantage? We basically looked at the before and since results in TCI cities aggregated by region or country, and then we compared those numbers to the performance of the whole region or country. We computed the difference between the two to estimate what we call as the TCI advantage. The results are summarized in the rightmost table. There is an advantage in most countries, ranging from 0.05 percentage points in Senegal to 1.49 percentage points in Tanzania. In Benin and Senegal, the differences are marginal, plus 0.05 percentage points in Senegal and negative 0.05 percentage points in Benin. Now, the population-weighted average of the TCI advantage is 0.78 percentage points. It is worth noting that FP 2020 had a goal of increasing MCPR growth to 1.4% per year from a historical rate of 0.7% per year, which amounts to a 0.7 percentage point increase in MCPR. Now, assuming accuracy and comparability of HMIS data across the different countries and their consistency with survey data, overall, what we can tell from this data so far is that TCI cities have exhibited a performance differential, which may be in line with FP 2020's intended acceleration in MCPR growth. The data and analysis presented provide evidence supporting TCI's positive contribution to increasing FP uptake in its partner cities. In TCI's next phase, TCI will continue to strengthen its monitoring and programming to track and improve performance in the cities it is actively supporting. As more cities graduate from engaging with TCI, we will also continue to monitor their performance after graduation. This will give us the opportunity to assess the sustainability of TCI's high-impact interventions in its alumni cities. We hope to share those updates with you in the future. So for now, thank you for your attention, and I look forward to answering any questions.
Thank you, Ian. A question, are we ready now for Alex and his colleagues' presentation, or should we pass on to the third presentation? If Alex's presentation is ready, please start it.
We're trying to get it up, so why don't you go to the next one and then we'll do Alex right afterwards? Great.
Okay, well, the next presentation then will be made by Zeba Zattar and her colleagues. It's bad when she only puts initials, Mr. or Mrs. Arif and Maqsood Sadiq. on Pakistan, more than 50% urban, a possible game changer for Pakistan's slow and staggered fertility transition. So if you could put that up now, Nancy, I'd appreciate it.
Good morning, good evening. It's indeed a pleasure for Maqsood Sadiq, my colleague, and I to be part of this session. This is part of a larger project on urbanization we're doing with Population Council colleagues here and in New York. Pakistan is really an intriguing puzzle for many demographers because quite a rapid decline in fertility in the 90s. Progress has slowed down. Another interesting feature about Pakistan is that it urbanized much earlier than other South Asian countries, though they are now caught up, but Pakistan was urbanized at a much earlier stage at higher levels. And recent work that we are doing that we refer to here, actually we find that whereas the UN projections say that we'll be 50% urban by about 2045, actually we estimate that administrative definitions have probably undercounted, especially in the censuses, the level of urbanization, and we're probably at 50% or close right now in 2021. Therefore, this raises many questions about how does being more urbanized really affect fertility. So just a glimpse at other South Asian countries, we see that despite substantial urban-rural differentials in fertility in Pakistan, they were narrow, they're much larger now, but still urban fertility is barely at the levels of rural fertility in Nepal and is much higher than levels in India and Bangladesh. So questions do arise about when urban fertility in Pakistan will actually catch up with urban fertility in other parts of South Asia. So the research questions that we are asking are really, as Pakistan approaches its 50% urban, population becomes 50% urban, will this be the tipping point for Pakistan's relatively slow and delayed fertility transition? So do changing urban-rural differentials offer some sort of answers? And does urbanization seem to also offer the kinds of social change, ideational change, and extension of services that we expect accompany urban settings to be kicking into reproductive behavior? And particularly, we try and start to look at the influx of migrants, because after all, a large part of migration is the influx of migrants. And how do they behave? Is it a melting point? Are urban areas a melting point for migrants from all over the country? Or do they take their time in adapting to fertility behaviors in urban areas? Well, one thing is for certain, and as I said, and I thought it was a nice nostalgia to look at the 1975 Pakistan Fertility Survey to see that there was hardly any urban-rural fertility differentials at all, that these are now sharp. And the real decline in urban fertility actually happened between about 1975, and of course it had happened by 1991. But the rural change really happened after that. It has happened between after 1997, about 2007. But since 2007, there is a one-child difference between urban-rural fertility rates, TFRs, but they still remain pretty high. One of the changes that has happened in Pakistan is really definitive. That is that the age at marriage, and it has contributed to the decline in TFRs, the age of marriage of women has really risen dramatically. This also distinguishes Pakistan from other South Asian countries. So just indicative of that, the percentage who are married at 2024 is almost half, both in urban and rural areas. At the same time, then we would expect that this would also affect contraceptive behavior, but that is not the case. When we look at the demand for contraception, we begin to get the clues to the answer of why change is so slow in Pakistan. Particularly looking at the urban overall demand for family planning, we see that it has not only not changed much since 1991, it may be back to the levels of 91 after rising for a while. And this is quite different from what we would expect, about 70% or so by now, based on other indicators. And clearly within the explanation lies the issue of the the demand for modern contraception, which seems to be particularly weak in the Pakistani setting. We then look at contraceptive use, actual contraceptive use, and you can see that there is a dramatic decline from about 10% to 43% in urban areas. But then it hasn't risen much since 2007. I think that's the dramatic finding. Whereas in rural areas, it's inching up and possibly catching up in another few years with urban contraceptive prevalence rates. And embodied within that are high, pretty substantial use of traditional methods, especially in urban areas, which seems again confirmation of a kind of rejection of modern contraception or hesitation to use modern contraception. We now move to dig deeper into explanations for why they have urban fertility has not declined in the last decade particularly. And of course, we would expect at least the educated women to have higher levels of contraceptive use. They do, even in 2071, but they did so at the same levels in 1991 as well. So educated women have hardly changed. It is the uneducated that have really caught up quite a bit dramatically. On the left side, in terms of income, again, the rich, obviously richest group do have much higher levels of contraceptive use, but it is really the catch-up of the poorer groups, though they still remain at much, much lower levels than the rich groups. Unmet need, of course, takes into account overall demand, and we see that here the position becomes, the picture becomes complicated, and we are seeing a kind of leveling off of unmet need by education in the recent 2017-18. I mean, it's in fact a very, very sort of almost a flat line, if you were just to connect the poorest and the richest. They have about the same levels of unmet need. Again, a challenging question. There are more definitive differences between the poorest and the richest group on the left in terms of unmet need, but the education differentials are really kind of intriguing. We tried to pool all our data together in one regression and pooled the three demographic health surveys to get a perspective of time. First of all, we look at rural-urban differentials and urban contraceptive use. The dependent variable is of about 40% higher odds in urban areas. The comparison between 1991 and 2007 shows that there was about three times the probability of using contraception in 2007 compared to 91, which is fairly dramatic. But the change between 2017 is much lower. So change has staggered off. In terms of education, it becomes more of a curvilinear relationship with the middle and secondary groups having higher contraceptive use rates almost than the secondary and higher. And again, across income, this is the most consistent relationship. It's a strong relationship with the rich having about 2.7 the odds of using contraceptive use compared to the poorest groups. So income reflecting ability to pay, distance to services remains a stubborn and strong indicator of adoption of contraception. The next line of inquiry that we went into, next please, was really to try and see, we know that high levels of urbanization reflect high in-migration, new migrants always coming into cities. And this was reasoning behind Sindh, our province of Sindh, questioning the DHS results last time, saying, we expected our highly urbanized province to have, with a lot of inputs into the family planning program, to have much lower fertility. Perhaps it's the influx of large proportion of migrants into Karachi. Well, here's your answer. Yes, the TFR, reflective of a whole host of factors, fertility, marriage, contraception, etc., do have higher fertility than non-migrants, almost 0.7 child in urban areas. That's the pink and yellow bars. And they also have higher fertility than rural areas, which is, of course, interesting, because it seems like migrants are a special kind of different group. And it may be reflective of also a lower level of child and infant mortality that they experience in urban areas. We dug deeper into effects of being poor. That means living in, being a migrant, being poor, and having migrated more than 10 years ago or less than 10 years ago. I think the more than 10 years ago is intriguing again, because it does imply that the pink bar, the poorest migrants who came into an urban area more than 10 years ago, still have the highest unmet need of over 15 percentage points. And I think that is compared to 5 percentage points if they are rich, meaning that they live in far off slums, kachi abadis as we call them, not permanent housing, where services are sparse. And maybe also in terms of imbibing ideas about planning families, etc., and communication services also, and information are hard to get in those areas. Towards the end, we look at services, because it seems like it's all around availability of services, information as well. But in ways that's an equalizer, because if it's on mass, the few messages that we are receiving are really on mass media, then that is available to, even to the poor in urban areas. But actual services are quite different, as you can see, for the poor and the rich. For the poorest women in urban areas, now we're just looking at urban areas, the majority in 1991, about 60% relied on the public sector, and about 45% still rely on the public sector, though the preferred choice is really to go to private sector providers. That has increased, that proportion in blue has increased, but it's not substantial compared to the right-hand side, where the rich relied always on the private sector and rely even more so. The majority just go to the private sector. Then we turned to some work that we did for the Gates Foundation on doing a landscape for time planning services, knowledge, etc., back in 2016. And looking at a GIS map, in fact, it's a census of all facilities, and we did it in a lot of settings, but I'm deliberately chosen to show you Faisalabad district, which is a major urban area of Pakistan, houses 3.2 million people. That on the top bar, the sparsity of services in Pakistan is really striking. Public facilities in a large district like Faisalabad are 365, and 90% are providing the minimal of services, 90%. But if we go to 3+ methods, it probably dropped to 70%. On the lower bar, private facilities, which are 10 times more numerous, than public facilities. But on the right-hand side, and the background, we have the density of service. So you can see that private services follow the density of the population. That only 13% of private providers or facilities are providing one method. And that is a flaw in and limitation of the program and programmatic efforts in Pakistan, that we have not utilized the for-profit private sector, though it is being utilized for a lot of health needs, including other reproductive needs such as delivery and abortion. To conclude, I would say that urban fertility is still one child lower. So whatever change does happen in Pakistan, it will happen first in urban areas. But the speed of the change seems thwarted, and I think we've got some strong ideas about what is causing the lack of urban education. I think differentials is really quite striking. But in particular, the overall demand for contraception is staggering at a certain level, and particularly modern contraception not being used, or the demand for it not having risen over the last 27 years is really striking. There is parallel data that there wasn't time to share on the use of abortions, and there are the abortion rate in Pakistan is extremely high, the highest in South Asia. So I think it is a trade-off about what methods people are using to get to their fertility goals. Income does retain a strong negative influence that reflects that services do follow where the money ability to pay is, and where the rich live is where the services are more accessible, more plentiful. And I think I've hinted to the fact that, not hinted, but pointed to the fact that the low-cost private sector would be an equalizer, which would really expand access for these poorest groups. So that were to happen, we can expect very rapid change to happen in urban areas. Thank you very much.
Okay, thank you very much, Zeba. Very interesting presentation. Are we now ready for the presentation by Alex, Maurice, and John Cleland? Good.
Thank you for joining us in this session on new evidence on urban fertility and family planning in Sub-Saharan Africa and South Asia. This session has been sponsored by the IUSSP Panel on urban family planning. Our presentation is on contraceptive use patterns in urban Africa, examining trends in rich-poor gaps. I would like to acknowledge my co-authors, Drs. Maurice Anyawe and John Cleland. Africa will continue to drive global increases in world population up to 2100 and beyond. Most of this growth will be in urban areas. By 2050, almost 1 billion Africans will be living in urban areas, up from under 500 million currently. Also, Africa's contribution and its share of the global urban population will almost double from 11% in 2010 to 20% by 2050. These trends are largely driven by a natural increase, which is the excess of births in urban Africa over deaths in urban Africa. The significant role natural increase plays in urban population growth in Africa is driven in part by unplanned childbearing, especially among the urban poor. Prior studies have shown that poor women in urban areas in Africa have higher fertility than their richer counterparts, and they are less likely to use modern contraception. With majority of the urban population in Africa living in slums, poor urban women constitute a large proportion of the total urban population, and their fertility and contraceptive use patterns will increasingly determine overall patterns observed in Africa. In a 2010 paper I published with colleagues at the African Population and Health Research Center, we showed that, that in most countries, the level of contraceptive use among the urban poor were close to those of women in rural areas and much lower compared to women in richer households in urban areas. In this particular paper, in 22 of the 26 countries included in the paper, women in richer households in urban areas were at least 50% more likely to use family planning than those in poorer households. And in half of the countries, the gap is almost 2 to 1 in favor of women in richer households. In countries like Rwanda, Nigeria, and Benin Republic, the gap is actually 4 to 5 times higher between urban women in richer households in urban areas and those in poorer households. These results have also been validated even by more recent studies by other researchers. In one of such studies, which is a multi-country study by Helwig and colleagues, and based on 43 surveys from 43 African countries conducted between 2010 and 2018, they found large differences in the proportion of demand for family planning satisfied between urban poor women and urban rich women. Our key question is whether these gaps between urban poor women and urban rich women in terms of fertility and family planning outcomes have changed over time. We are particularly interested in comparing levels observed in the early 2000s with trends in the recent period, given that the 2012 London Summit on Family Planning called for increased investments in family planning, especially targeting poor women. In particular, a number of programs like the Urban Reproductive Health Initiative and its successor, the Challenge Initiative, have worked effectively in partnership with local authorities in over 100 cities, many of them in Africa, to improve access to and demand for modern contraception. A major focus of these programs is on addressing inequities in access to modern contraceptives, with most specifically focused on the urban poor. If these programs have been effective in improving access to modern contraception, the impact will be most evident in improved access among the urban poor and in addressing existing inequities in modern contraceptive use between poor and non-poor women in urban areas in Africa. We use 38 demographic and health survey data sets from 19 sub-Saharan African countries with surveys in both the early 2000s and between 2013 and 2019. We focus on currently married women, and our key indicators are use of modern contraceptives or modern contraceptive prevalence rates, sources of contraceptive supply, which we defined as public, private, and other, and the proportion of demand for family planning satisfied by the public sector. Our hypothesis is that inequities in contraceptive use between rich and poor urban women is a reflection of poor access to affordable contraceptives among urban poor women. Public sector provision of family planning services will improve access among the urban poor, thereby eliminating inequities in modern contraceptive prevalence rate between the rich and the poor in urban areas. Given the strong differences in modern contraceptive use between East and Southern African countries on the one hand and West and Central African countries on the other, we present the results separately for these regions. As with previous studies, we show significant differences between urban rich and urban poor women across all countries in East and Southern Africa in the prior period, except for Tanzania, where the differences, though about 10 percentage point difference, did not achieve statistical significance. Over the intervening 10-year period, the gap between the rich and the poor had disappeared in all countries in East and Southern Africa except Ethiopia and Uganda. In these two countries, there was no change in contraceptive prevalence among both the rich and the poor in urban areas over the 10-year period. With the exception of Namibia, the elimination of inequities in modern contraceptive use by wealth status in the recent period in East and Southern Africa was driven largely by significant increases in modern contraceptive prevalence among urban poor women. In Rwanda, for instance, modern contraceptive use among urban poor women more than quadrupled between 2005 and 2014. The exception of Namibia is a country where shows significant decline in contraceptive use among the rich, which then brought them closer to the level. But even the poor did see a very minimal increase in contraceptive prevalence. In West and Central Africa regions, significant gaps in modern contraceptive prevalence rate existed between rich and poor women in urban areas in the earlier period in 7 out of the 10 countries. Over the following 10-year period, the gap remained or became significant in 8 of the 10 countries, with Ghana and Senegal as the only exceptions. Across these countries, contraceptive use remains significantly higher among the rich than the poor in urban areas. Liberia presents a different exception as the only country across the 19 countries included in the survey where urban poor women were significantly more likely to use modern contraception compared to the urban rich. What explains these divergent patterns between East and Southern Africa on the one hand and West and Central Africa on the other? Our hypothesis is that the provision of family planning services in public health facilities will remove financial access barriers to use for urban poor women and consequently address inequities in use of modern contraception by wealth status. We examine this by looking at trends in the proportion of rich and poor women procuring their contraceptive supplies from public sources. We focus here on the urban poor and examine changes in the proportion of poor urban women getting their contraceptive supplies from public health facilities. The blue bar shows the earlier period and the gray bar the later period. Across countries in East and Southern Africa, the role of the public sector in meeting poor women's contraceptive need is much higher than in West and Central Africa, and that role has increased over time. In countries like Malawi and Rwanda, the proportion of poor women getting their contraceptive supplies from public sources have more than doubled over time. Compared to countries in West and Central Africa, public sources account for a much smaller part of the source of methods for poor women. And in a place like Mali, its limited role has further declined, which is consistent with a decline in the proportion of poor women using modern contraception in Mali. Senegal, which is the only country in West and Central Africa where prior significant gaps in modern contraceptive prevalence between the rich and the poor had disappeared, also has the largest proportion of women getting their contraceptive supplies from public sources. And here, that is in Senegal, the role of the public sector in meeting poor women's contraceptive needs has more than tripled over the 10-year period. Finally, we looked at the effect of public sector programs on the proportion of demand satisfied. This is calculated as the product of the proportion of demand satisfied and the proportion of contraceptive users relying on public sector services. The value of PFPI ranges from 0 in countries where there is no public sector family planning program to 100% in countries where a highly accessible and high quality public sector program serves all married women with a demand for contraception. The results show strong association between modern contraceptive prevalence rate and PFPI among urban poor women. The proportion of demand satisfied by the public sector is very low in West and Central Africa, where modern contraceptive use is also very low. In these regions, the public sector appears to have been playing very limited role in the provision of family planning services. In East and Southern Africa, the reverse is true, and these countries are shown in the upper part of the slide. Our analysis shows that previous gaps in the use of modern contraceptives by wealth status has virtually disappeared in most countries in East and Southern Africa. This has been driven by significant increases in use of modern methods among poor urban women, which is due in part to significant increases in the role of public sector in the provision of modern contraceptives, especially for urban poor women. We conducted supplemental analysis looking at patterns in rural Africa by wealth status, and the results show significant gaps in modern contraceptive use still exist between the rich and poor in rural area in all regions of Africa. This may suggest a significant opportunity to further increase contraceptive use, especially in East and Southern Africa, where limited increases over the last 10 years among the urban rich may suggest saturation is being reached in urban areas in East and Southern Africa. The limited role of the public sector in the provision of modern contraception in West and Central Africa is concerning. These results suggest that addressing the continued high fertility and low contraceptive use rates in West and Central African countries would require strengthening of the role of the public sector in the provision of family planning services. The recent doubling of the proportion of poor women using modern contraception in Senegal and Liberia, with corresponding increases in the role of the public sector in the provision of family planning services, suggests that the high fertility and low contraceptive use patterns in West and Central Africa may not be as intractable as others may suggest. It does show that improving access to family planning among the poor, both poor and rich women in West and Central Africa, and strengthening the role of the public sector in the provision of such services is key to changing these patterns. Thank you.
Okay, we are ready for the fourth presentation now, please. If you could put up Bruno Schumacher and his colleagues' presentation, please. David Sanchez-Paez.
Hello and good morning or good afternoon, everyone. I'm going to present a work on fertility stalls in urban Africa, where, who, why, and this is a joint work with David Sanchez. And the background for this research is the fact that urban areas and large cities are at the forefront of demographic changes. It is well known that fertility is lower in urban areas, and it's the case in all sub-Saharan African countries. And it's usually even lower and much lower in cities. And this is due to a host of factors such as higher level of education, better access to contraception, and later marriage. But actually, fertility in urban areas remains fairly high in sub-Saharan Africa. And at the same time, stalls have been identified in several sub-Saharan African countries since the early 2000s. But these stalls have been little studied in urban areas. So in this work, we will focus on the fairly high level of fertility in urban areas and whether they reflect stalls in fertility trends in urban areas and in cities. So the objectives of this research is first to identify where stalls have occurred in urban sub-Saharan Africa. And for this, we reconstruct fertility trends in cities and in other urban areas. The second objective is to identify if these stalls are driven by specific groups of people, by migrants, by less educated people. So this is very much a work in progress, but I will show you a few results. And finally, what factors account for these stalls, which proximate determinants, and do these stalls result from unmet needs for family planning? I will also show you some preliminary results. So we use data from 37 sub-Saharan African countries coming from surveys, mainly demographic and health surveys, but also other surveys like MIX or WFS. These surveys need to be harmonized to be analyzed together. And these surveys need to be harmonized to be analyzed together, so to have the same structure of the data file, the same variable names, and the same definitions of place of residence. And one of the key issue here is to identify the capital city or the largest city, other urban areas and rural areas in a consistent way over time and across surveys. So a few words on the methods. To reconstruct trends, we pulled all the surveys from the same country after having identified the capital city or other urban areas. So this figure shows the fertility trend in the capital of Zimbabwe, in Harare, and we see that since the early 2000s, fertility has stalled, has even slightly increased. We use restricted cubic splines to smooth these trends and to identify stalls in orange or in red on this graph. And we do a similar thing for other urban areas. So this is also for Zimbabwe, where we see that fertility has stalled at around 3 children per woman since the early 2000s. So what do we find when we look at that in all the cities? We find that in 18 of the 37 cities, so half of them, fertility has been stalling in recent years. So we have 18 ongoing stalls, and it stalled at some point in the past in 5 other cities. So this is a very frequent phenomenon. And in urban areas, other urban areas, fertility has stalled in 10 countries in recent years. So what it shows is that fertility stalls are mainly an urban phenomena, and it's especially frequent in large cities. So I will show you a few cases to illustrate the variety of stalls in Sub-Saharan Africa. So these are all the stalls, the 18 stalls in Sub-Saharan Africa, and the first one here I show is Niamey, where fertility has stalled since the early 2000 roughly at between 5 and 6 children. Another example is Accra. So fertility is at much lower levels, a little below 3 children, but fertility has also stalled for roughly 20 years. Next example from a big city, Lagos, where fertility has also stalled roughly since the early 2000s at more than three children per woman. And finally, a recent stall in Kigali in Rwanda with the most recent survey, DHS survey. So roughly since 2015, fertility has stalled also above 3 children. And we also find stalls in other urban areas, for instance, like in other urban areas in Benin, and another example in Congo, other urban areas in Congo at about 4 children. So are these fertility stalls due to specific groups of people? And we might think that migrants coming from rural areas with higher fertility would disproportionately contribute to stalls. Well, it's not easy to answer these questions because of lack of data, but we can compute in some cities, we can compute fertility trends by migration status, and we compare fertility trends for migrants and non-migrants, for instance in Cotonou, and we find that both for migrants and non-migrants, fertility has stalled since the late 1990s. We find similar results in Lagos, even though the data are not perfect, and in Yaoundé and Douala in Cameroon, for instance. So it seems migration is not really responsible for these stalls. So we'll look further at stalls by level of education, but I don't have preliminary results to show you now. Next questions: which proximate determinants account for these stalls? So we look at 3 proximate determinants: sexual exposure, postpartum infecundability, and contraceptive use among sexually active women. And I'll show with 3 examples that there are some commonalities but also some differences. So here is the case of Yaoundé and Douala, and we find that actually contraceptive use contributed to increasing fertility. So this is the fertility inhibiting effect of contraception, and we find that it contributes to increasing fertility. Postpartum infecundability also contributed to increasing fertility, and it was offset by the trend in sexual exposure, contributing to a decrease in fertility. So when we combine these 3 trends, we see that it contributes to a stable level of fertility predicted from these proximate determinants. And in Tanzania, Dar es Salaam, we find that contraception contributed to decreasing fertility, but it was offset by the trend in postpartum infecundability. So postpartum infecundability is shorter now than it used to be, and in recent years trends in sexual exposure also contributed to increasing fertility, and when these 3 proximate determinants are combined, it leads to fertility stalls, and we find something similar in Nairobi, for instance. And finally, do these stalls reflect unmet needs for contraception? So we looked at different ways to answer these questions, but this one shows several scenarios. So in black, you will find the trend in the total fertility rate in Cotonou. In purple here, this is what we would have observed if there were no unmet need for limiting fertility. And in yellow, the trend in the total fertility we would observe if there were no unmet needs for limiting and for spacing children. And we find in Cotonou that the level of fertility would be lower if there were no unmet needs, but the trends would be fairly similar, so it would even be a little bit increasing. And this reflects the fact that the demand for children remains high in this city. And we find similar results in Harare. So in Zimbabwe, we find similar results in Lagos. So said briefly, unmet needs for family planning do not explain trends in fertility in cities, even though fertility could be lower if women had a better access to contraception for spacing and for limiting their fertility. So in conclusion, fertility has stalled in many cities and in urban areas, and it seems that the decreasing length of postpartum infecundability is a key factor, and sometimes it's combined with a slow increase or even a decrease in contraceptive use, and with an increase in sexual exposure. Unmet needs for family planning do not seem to explain the stalls in most cases. Fertility would be lower with met needs for family planning, but the trends would be fairly similar. And actually, the demand for children remains high and has not decreased substantially in many cities. Migrants do not seem to contribute substantially to stalls in the few cases we have been able to analyze. And further work is needed on the role of the less educated people or the poorest people in these trends. So further research is clearly needed on the causes and the implications of these stalls, and a question is whether these stalls herald trends in other places of residence. So do these stalls in African cities mean that we are likely to observe stalls at the country level in the future? Thank you for your attention.
Okay, thank you very much. A very good presentation. We are now going to turn to Nkechi, who is going to be the discussant for this session. You have about 10-15 minutes.
Thank you very much, Tom. So I'm pleased to provide some comments on the presentations that we have just listened to. So I'd like to quickly summarize some of the papers quickly before I get into it. So we listened to 4 presentations based on research in Sub-Saharan Africa and then South Asia. So the paper by Eze and his colleagues explored trends in the gaps in modern contraceptive use between urban rich and then urban poor women in the Sub-Saharan African context. And they found that these gaps are decreasing over time, and these are largely attributable to public sector family planning programs. Ian's presentation showed that there has been an increased uptake of family planning programs and services over time in TCI member countries. The presentation by Schumacher also demonstrated the presence of fertility stalls in urban cities in Sub-Saharan Africa. And then Ziba's presentation also provided questions on the role of increasing urbanization in Pakistan's fertility experiences. Now, in 2018, the report from the UN Department of Economic and Social Affairs predicted that by 2050, we should see a sizable increase in the world's populations, and particularly in cities. Now, presently, about 55% of the population, of the world's population lives in urban areas, but this is expected to increase to about 70% by 2050, essentially adding an additional 2.5 billion people to our population. Now, 90% of this population growth is expected to take place in Sub-Saharan Africa and then also in South Asian cities. So this is particularly China, India, and then Nigeria. Now, these growing populations will place some extra demands on cities' resources and services, and therefore there's the need to try to generate sustainable policies to manage this expected growth in our urban populations. So this provides the rationale for this panel's focus on urban fertility. But why the focus on family planning? Well, as you may know, population growth could be as a result of migration or natural increase, as has been said during the presentation, and family planning has been identified as a good way to tackle the latter. Why then do we focus so much on the urban poor for this panel? Well, there are two possible outcomes when we think about the implications of urbanization for fertility. Well, first, people who are in urban areas could avail themselves to better levels of services that could lead to a decrease in their fertility, as was hinted in Ziba's presentation. We could also see a situation where increasing urbanization, coupled with fewer employment opportunities, could see poor people, could see the increase in the population of the urban poor. And if these individuals cannot afford access to sexual and reproductive health services, we could see an increase in fertility. Or if these urban areas are simply a little overwhelmed and therefore unable to provide these essential SRH interventions for the poor, we could also see increases in fertility, which is why in Ziba's presentation, she hinted at an increased role for private providers to try to complement what we already see public providers doing. So it is for these reasons that we anticipate that much of the growth that we might be seeing in 2050 will stem from the poor in these urban areas. This is a very important reason for interventions like what Ian talked about, the TCI. So this is work that goes on with governments in various cities to try to increase access to contraceptives and also family planning programs. Now, from the presentations that we listened to, there are very important positive effects being seen. So for example, presentations by Eze and then Sata show that the gap in contraceptives access and use appears to be decreasing between the urban rich and then urban poor women over time, which is great. Silas's presentation also emphasized the presence of a TCI advantage in member cities. So cities that are a part of this intervention appear to experience increased uptake with respect to modern contraceptive use. But I think that it's important to point out that despite this increasing access to family planning programs, we are not seeing concurrent decreases in fertility in the sub-Saharan African context. So this is according to research that was presented by Schumacher, where he found that despite increasing access to family planning programs, as the other papers showed, fertility appears to be stalling in several cities on the continent. Now, what about the role of migration in the different cities' growth experiences? So apparently, even though earlier on there was a statement that a lot of this growth in cities that we would see would result from natural increase, perhaps it will depend on the part of the region of the world that we are focusing on. So when we listen to Ziba's presentation, migration is going to be important for South Asia's fertility experiences, because we saw that fertility stalls among migrants, particularly those who have recently migrated within the last 10 years, appear to be higher than for non-migrants. With Schumacher's presentation, on the other hand, perhaps migration will not be so important for sub-Saharan Africa's fertility experience, because the trends didn't differ between migrants and then non-migrants. So as I mentioned before, perhaps these experiences with fertility will depend on the particular country context and the role that migration will play. And it's important, of course, to take note of these nuances, because they will be important for the design of appropriate interventions. Now, these presentations were really interesting and stimulating, but I do have a few more lingering questions that I'd like to table at this point. So I found it interesting. Why is it that even though we see increasing access to family planning services, especially among the urban poor, some of the research indicated, why is this not translating to decreasing fertility within these countries? I mean, 10 years after the 2012 London Summit, where a lot of countries, pledged to pay more attention to issues of contraception and then reduction in unwanted or mistimed births, why do we continue to see stalls, particularly in our cities? Also, the research that was presented certainly showed that we are seeing increases in modern contraceptives over time. But we would agree that the uptake is still relatively low. For example, in Nigeria, according to the most recent demographic and health survey, only about 12% of married women are using modern contraceptives. So why is this the case? In South Asia, for example, Ziba referenced the greater prevalence of traditional methods, for example, and also that potentially abortion could be used as a substitute for modern methods. So what are some of the other reasons why, despite our best efforts, we are not seeing increases in the uptake of contraceptives? And I also wondered why there's so little focus on rural areas. So for example, with TCI's interventions, as was presented, there's a heavier or greater interest in what's going on contraceptive uptake in cities and urban areas. Well, one could argue that with the report I talked about, the 2018 UN report, a lot of the population growth will happen in cities. So perhaps not focus so much on rural areas. But we know that rural areas will also contribute to a country's total fertility experience. Indeed, from the same report, we know that Africa and Asia are home to nearly 90% of the world's rural populations. And Eze already emphasized that these areas have low access to family planning programs. But again, perhaps this limited focus on rural areas is justified because Schumacher in his presentation did mention that fertility stalls, there are fewer fertility stalls happening in rural areas. Indeed, if I remember correctly, the statement was that fertility stalls are more of an urban phenomenon. But then I found myself wondering exactly what he meant by fewer stalls happening in rural areas. So is it that fertility rate declines are very persistent in rural areas in Sub-Saharan Africa, in which case, that's great, maybe no need for so much focus on rural areas? Or perhaps is it that there are no persistent declines in fertility happening at all, so that stalls are not even a matter for consideration? Then that wouldn't be so great. And then we go back to the original question, why not focus more interventions on our rural areas? I also wondered whether we could potentially be underestimating the role of traditional contraceptive use in these stories that we're telling. So with the exception of Ziba's paper, other papers tended to focus more on the use of modern methods. But we know that there are challenges with these as well, because women sometimes say they don't want to use modern methods because they're afraid of the side effects. There are issues with supply. So I wondered whether perhaps the low uptake of modern methods is because women are using more of these traditional methods. Are they substituting these, are they using more methods and instead of more traditional methods rather than focusing on modern methods? And if these traditional methods are more ineffective, is that why we're seeing stalls in our fertility trends? So I just wanted to point out that I think after this session, there's going to be another session that sheds more light on the practice and prevalence of traditional contraceptive methods in the African context. It might be interesting to just look into this session just to see if there are any potential explanations or roles that traditional methods may be playing in the stories of fertility in the urban context that we're trying to tell within this panel. Finally, I wondered whether it's possible to talk about family planning in the African context without talking about men, right? And yes, the setting is in urban areas, and there's the assumption that men in these settings could be more open-minded to options for preventing unwanted or mistimed births. But we're dealing with two groups of people within urban areas, the urban rich and then the urban poor. And these individuals may have different inclinations or preferences with respect to fertility. I think that we all know that there are also acknowledged consequences for women using contraceptives without their male partner's permission. So things like increased violence, divorce, a man taking on additional wives if he feels one or two of them are using contraceptives without permission and not giving the amount of children that he may want. So I think that also the stalls that we talked about may reflect still high demand for children, not just by men, but also, not just by women, but also for men. And therefore, in thinking about some of these interventions, we may want to think about also the role that men may play in trying to increase the uptake of family planning programs, particularly in patriarchal societies like in Sub-Saharan Africa. And I was happy to see that in the interventions that Silas talked about, he mentioned that male engagement was one of the options being considered, particularly for India. I do have a few more minutes, and I'd like to get into just one or two specific comments about the papers that were presented. Now, for the paper presented by Eze and colleagues, a lot of the use of or the uptake in modern contraceptives was attributed to public services or public service provision. But I thought that there were some inconsistencies in country experiences. So, for example, in Tanzania, we saw a fall in public provided services over time, but an increase in modern contraceptive use over the same period. In Ghana, we saw an increase in public services, but a decrease in modern contraceptive use over the same period. And I thought it may be useful to speculate on what other factors may be contributing to the uptake of modern contraceptive use in these settings. I also think that in the paper, there was an attempt to sort of, there was a positive correlation that was seen between the PFPI and modern contraceptive uptake. And I think that this association wasn't too surprising, because if my understanding of the construction was on point, well, then the former has been largely constructed out of the latter. So it's almost a mathematical certainty that we will see some correlation. So I think that if we want to assess the impact of public sector programs on modern contraceptive uptake, we may need to have more robust constructions and methods in order to validate that attribution. Now, with the paper by Schumacher, I think, as the presenter said, this is a work in progress. I think it's still an outstanding question as to whether these or how these observed stalls differ between urban rich and then urban poor. I think it would also be interesting to sort of try to aggregate that to the sub-regional level to see whether these stalls are happening differentially between particular parts of Sub-Saharan Africa. So we know that the fertility experiences in, say, West Africa and South Africa are different. So it'd be interesting to see whether the stalls are also similar or happening in different fashions. And then we noticed that most of the stalls presented in Schumacher's paper were happening around the year 2000. And I wondered if he had any speculation as to what might be so special about this date. Of course, his findings are consistent with others by like Kebede et al. In 2019. And these researchers attributed these stalls to earlier stalls in education in the 1970s and the 1980s. And I wondered if you agreed with this position. And then if that's the case, should the solution be geared more towards increased investment in education or still with family planning or both? With Silas's presentation, I just assume that when we talk about all these family planning methods and access to contraceptives, these are a means to an end. The end being a reduction in unwanted births, mistimed births, particularly in these urban poor areas. I wondered if the organization or the TCI had tried to evaluate or assess the presence of a TCI advantage in fertility, for example, where you see whether the program is actually impacting fertility rates or population growth rates in member cities. I also wanted to find out if it's possible to clarify whether the TCI targets the urban poor or just the urban population in general. And if the urban poor is not targeted, are there specific programs meant to target this demographic within the local government areas that TCI is collaborating with? And I would also appreciate some intuition as to why TCI involvement in these Francophone West African countries actually leads to a depression in the adoption of modern methods. I thought this was a little counterintuitive. And then finally, the presentation by Ziba, I wondered why the overall demand for contraceptives methods was stagnant in urban areas and whether this varied for both urban rich and then urban poor women. It would also appear that the traditional methods were more important than the modern methods in urban Pakistan, if my understanding of the presentation was right. And I thought this was a little unexpected because with increased urbanization, access to information, exposure, we would assume that women in urban areas would embrace more modern methods, but we don't see this pattern in Pakistan. So I wondered if you had any speculations on why this was the case. So these are some of the comments I wanted to share. Thank you very much for the opportunity to review these really great, interesting papers. Thank you.
Thank you very much, Nkechi. That was very interesting. I think I have a real quandary in that we only have about 10 minutes left and we have had a bunch of very interesting presentations, a bunch of questions. I want to make time for the audience to ask questions. I'll ask the presenters if they have something they feel they need to say, but please keep your comments short. We've had at the same time simultaneous very interesting exchanges in the chat. I can't resume them. What I think I would like to do is immediately after you speak, I'll just say anybody who wants to say something, raise your hand, and in the very little bit of time we have left, we'll try and do it orally. Okay, so why don't I give people a chance to speak? I'll go along the order that was originally planned. Start with Alex and his co-authors, and then go to Ian, Zeba, and Bruno. Alex.
Thanks, Tom. And thank you, Nkechi, for those summaries and comments on the papers. I think it's really great to hear all of those. In terms of the comments on the PFPI, I think you are absolutely correct. We've discussed this within the team and thinking how we address that and demonstrate the importance of the public sector provision of family planning services. So we're still looking for a better way to actually demonstrate that. In terms of the inconsistencies you identified in places like Tanzania and Ghana and others, you will also note that those differences and declines or changes were not significant. So it really does not counter the overall conclusions that we were able to draw regarding the role of public sector provision of family planning services and contraceptive use, especially for the urban poor.
Okay, go on to the next person, please. Ian.
Yes, thank you, Nkechi, again for your comments and your really nice summary. With regard to your specific questions, definitely we are interested in tracking fertility changes, but the data currently doesn't allow us to be able to do that. It's also the case that we're talking about TCI implementation being 2 to 4 years, depending on the place. And perhaps it takes a while longer for fertility impacts to be seen. Regarding your question around targeting the urban poor, TCI is focused on, yes, definitely on urban poor settlements, but helps local governments to provide services for the whole entire city, not just the urban poor. And regarding the Francophone country result, I think it was a slightly negative in Benin, and it's probably just a small, insignificant negative too. So perhaps not really saying that there was a decline coincident with TCI. Thank you.
Thank you. Zeba, would you like to take the floor?
Yeah, hi. Thanks again, Takeshi. Those were really fantastic comments. I wanted to quickly answer your question about traditional methods. I do think that there is a pattern, and we've really done in-depth studies on this, but it is an issue that the urban and the educated, even in the rural areas, do have a preference for traditional methods. Whether they're using them in tandem with abortion, we don't know, but withdrawal is really in fact, it is possibly the most preferred method. And I think it's largely to do with safety. There are concerns about safety, about modern contraception, and to do with quality of care, if we can go into that. So it's a deliberate preference. As I said, we've done in-depth studies. It's not an accidental thing that we are finding this very, I've just come from Punjab, where the dominant method is withdrawal in condoms, and everything else is under 5%. In terms of overall demand, again, this is really intriguing why demand is so limited for contraception, and the rich and poor differences aren't that huge. It's the actual use that differs, but overall demand is about the same. So we are struggling to disentangle, but there is something similar to the stalls that we are seeing in Africa, in parts of Africa that Bruno talked about, that seem to really point to the same thing happening here in Pakistan. So thank you very much.
Bruno, would you like to say anything quickly, please?
Yes, just a quick answer. First, thank you for the comments, very useful comments, and suggestions for looking at differences between rich and poor, or aggregate trends at the sub-regional level. And for pointing the year 2000, it's true that a lot of stalls start around year 2000. We have not identified the cause for this one. Well, the reason for this turning point. We have started looking at different hypotheses at the national level in a subset of countries, but not in capital cities. So I don't have the answer yet, maybe someday. And looking at education stalls, actually we have started the different approaches from the one used by Quevedo, and it seems that we also find stalls by level of education in the countries where we have identified stalls. Again, we have not looked at that in urban areas specifically, but at least in Zimbabwe, Namibia, and countries with countrywide stalls, we find stalls among the better educated also. So I'm not sure it will help us explain stalls in urban areas. And I see there was a comment on adolescent pregnancies. We have not looked at that yet. And Matthias mentioned a very important thing on the chat about postpartum amenorrhea, and it has a large influence on fertility trends, especially in urban areas. So as he says, I think it's really worth looking at that in depth.
Okay, thank you. I'm trying to see the raised hands. I'm not seeing it on my screen right now. In any case, I just want to say I've been told that I have been made host so that we can continue this discussion beyond the end of the hour, and I hope that the presenters will. Yes, I hope the presenters will accept to remain on, and we will just 1 second, and I'll give you the floor. So I know Matthias Lurch had earlier raised his hand. I'll ask, I guess, Chander Sekar to ask a quick question, and then
It's not a
Matthias.
question. Thank you. It's not a question. Just that I do agree with Zeba that in India also, like, because I am involved in DHS, women within same month, couple within same month, use traditional and modern, but we only collect information on most effective method. I think there is a need of such studies that where even educated couple use mix, but generally survey, or there's a tend to report by investigator on modern methods. Thank you.
Thank you. Matthias, did you want to say something?
Yes, okay. Thank you very much. Actually, I already wrote in the chat, but thank you much for this presentation. It's really, really interesting. And it just made me think about the paper we just wrote this year with Nicolas Todt about the relationship between the duration of breastfeeding and the postpartum amenorrhea. And we observed that in countries that developed, for example, in Asia at a very fast pace and also had a fast fertility decline, breastfeeding duration stayed constant, but postpartum amenorrhea duration contracted a lot. And this was clearly related to progress in development. So as women have less harsh living conditions, the energy burden is more limited. So more attention should be paid on this period, just these postpartum periods, in order to avoid that women think, I'm still breastfeeding, I will not have an additional child. And if more attention will be put on that, maybe that the stalls may reverse quite soon. Thank you.
Thank you. I'm going to try and put on the gallery view so I see other people if their hands up. Otherwise, I actually have a couple quick comments. I don't see hands up, so if I don't, send me a message and say that my hand is up if you have. I just had, when I'm thinking of what I heard, Ian and Alex pretty much said that there is high unmet need. If you get it right, and I think implicitly with Ian, if you have a very engaged government and public force behind you, you're working in places where the government is willing to work with you, interested in working with you, that services work, good services work. There's an uptake in contraception. And yet Bruno shows that over the last 2 decades, almost nothing has happened in an awful lot of large capital cities in terms of overall fertility levels. And in these capital cities, there has generally been increasing level of education, often increasing levels of income, and yet nothing has moved. He has also showed, I don't remember if it was here or elsewhere, that there is fairly high fertility preferences, even in urban areas. And when I look at Bruno, I think, oh my God, it's going to be hard to decrease fertility levels and upkeep of contraception. And yet when I hear Alex and Ian, I say, oh, we're at the cusp of a major fertility decline. And I'm wondering, what is it? Is there reason to be optimistic? Is there, what would be the, how do we put these two messages together, which seem to be quite contradictory? If any of you feel like unmuting, please do, and feel free to intervene.
Tom, maybe I could just start off there and others can build on it. I think first is a sub-regional, sub-Saharan African analysis of fertility declines may not be very useful in many instances because the patterns that we observe in different sub-regions are quite different. And when we say there are stalls, I think there are countries that have made significant progress in fertility declines, and there are others that, so the question of really looking specifically at specific countries and seeing what are the patterns for both the stall and contraceptive uptake within those. And are we seeing these? So if we take a macro look across the sub-region, Sub-Saharan Africa, we will see these patterns, but they may be working differently in different sub-regions. And even within the same country, between urban and rural areas, like we've in our own paper, we've shown that indeed the gap between the rich and the poor has disappeared in East and Southern Africa in urban areas, but in rural areas, it has remained constant. So again, it's understanding that there are all these different dynamics going on, even within the same country. And we need to do more disaggregated analysis of both the fertility patterns and the contraceptive use patterns within countries and within sub-regions in Sub-Saharan Africa to understand these patterns much better.
Would anyone else like to step in here?
I have, yes.
Yes, Maurice, go ahead.
Yes, I also wanted to say that with the issue of fertility decline and contraceptive use in Africa, most of this higher uptake of contraceptive use by women in Africa has to do with the fact that they are often persuaded and they are often convinced by like this public education and programming about, oh, if you increase fertility, if you take contraceptive use, it has disadvantages and that advantages. So women tend to take contraceptive use, but then research is saying that even though they are taking the contraceptive use and there's higher patterns of contraceptive use in the region, the reasons for their uptake most of the times is because they are taking the contraceptive use to space their children, but not necessarily to limit childbearing. So we can have higher uptake of contraceptive use in terms of modern contraceptives. But then if the reason for most women using the contraceptive use is for spacing of children, at the end of the day, it will not lead to fertility decline. The fertility decline, the fertilities will still stall despite that more women are using contraceptives. We have these studies in Navrongo Research Center where Phillips and co have found that in rural areas like this, especially in Navrongo in Abais region, most women are using contraception because of spacing of children, but not necessarily because they want to limit their children. So throughout the area in which they studied, they have higher percentage of contraceptive use and modern in the injectables and all the pills and all that, but the fertility has remained high. And their conclusion was that it's because of spacing of children rather than the limiting.
Thank you. Anyone else want to jump in? Otherwise, I can throw out another comment just to stimulate discussion. Ian, Bruno, anybody else? No. Okay, I just had a very quick anecdote to tell you. You were talking about traditional methods of contraception or non-modern methods. Years ago, I did a small study that was never published with a Vietnamese colleague. And we found that in looking at contraceptive use, modern contraceptive use was most used among the mid-level education. The richest and most educated people used traditional methods. And we were thinking, this is weird. This is not what we expected at all. And then we looked carefully at it, and he brought out this explanation that in Vietnam at that point, there were worries over secondary effects like everywhere. There were supply breakages. People could not get the supply of pills and other things all the time. And the real well-educated knew how to use effectively the rhythm method, and they could do it well. So the choice of the elite was rhythm. It was not the pill. It was not other things, because they could use the rhythm method effectively. And people who are not quite as well educated or quite as rich or quite as urban were trying to get the pill and were facing shortages. So it's interesting. I think you also have to look a little bit at this, and the rhythm method can be the preferred method among quite a few people. Enough from me. Anybody else? I don't think the hands raised function is working. So unmute yourself if you want to say something. Zeba, do you want to say anything?
Tom, maybe just to add on the point you made, I think it was possibly Chanda that made the point earlier about the limitations that we face with the way the DHS survey is currently structured with respect to contraceptive use, that you are, as a field worker, you have to, even if somebody is mentioning 2-3 methods, you have to select which one is higher up on the list, which is seen as the most effective. So it's ordered that way somehow. And you are then limited by just observe that. And if somebody even is using the pill and the reading method, you only know about the pill as a current method that's being used, but you don't get the other information. And maybe we need more specialized surveys that can actually get at the magnitude of dual use and concurrent use of modern and traditional methods and all of those, to really understand what's driving it, and if these explanations are also valid in different countries in Africa. I think we will need such insights on methods.
Thank you, Alex. Anyone else have something to say? I don't. And maybe just 2 very quick comments. If TFR is not coming down, but spacing is increasing, or people are entering into childbearing a little bit later and spacing is getting larger, you would kind of expect a lower number of births and a slower growth over time, just because you're having larger spacing between generations. And I don't know if we've ever looked at that sort of a thing, which is kind of an interesting issue. Sorry, I forgot my other comment. No one else has anything to say? If not, I guess I will declare this session over. If unmute yourself and speak rapidly if you want to say something. I see no one who is courageous enough to do so. So I declare the session over and thank everybody. This has been I think this is a very interesting session. As I said at the beginning, this is a topic that